Good evening and welcome, everyone. My name is Claire. I'm editor of Medical Chronicle, and I'm joined here by Dr. Liesel de Waard for a presentation on managing and preventing birth-related wounds and post-cesarean section infections. This webinar has been sponsored by BSN Medical, a company of Essity. A bit of background about Dr. de Waard. She is an obstetrician and gynecologist working at Tygerberg Hospital as a general specialist and senior lecturer. She enjoys teaching and research and is currently working on her PhD on the topic of cesarean section training. In terms of her leadership, she's a founding member of the World Association of Trainees in Obstetrics and Gynecology, a founding member of South African Association in Trainees and Obstetrics and Gynecology, committee member and maternal death assessor to the National Committee on Confidential Inquiries into Maternal Deaths, coordinator for Maternal, Women, Children and Neonatal Forum for Cape Town Metro. Her current research interest is cesarean sections, teaching and training towards PhD degree. She is a recipient of a Discovery Foundation PhD grant. She has been published in 7 peer-reviewed journals and has 2 chapters in an obstetrics textbook. So who better than her to speak to us tonight on this topic? A bit of instruction about the webinar. If you have a bad connection, there's a box at the top of your screen that says reconnect. Please click this button if you have any issues. It'll bring you right back into the webinar room. There will be a recording of this webinar available to watch. CPD points are allocated based on viewing time, so please do watch the full presentation or at least 40 minutes. As per HPCSA guidelines, we no longer issue CPD certificates directly, but pass on this data to the HPCSA, where you can view your points on their portal. Please type any questions that you have in the Q&A only box provided. It's next to the chat tab. It says Q&A only, and if you could use those for questions that Dr. de Waard will get to after her presentation. I need to point out that we will not be addressing any off-label use of products, and as per CPD requirements, no brand names are to be mentioned, active ingredients only. Just before I hand over to Dr. de Waard, if you consent to being added to Essity's attendance register for tonight, please type the letter Y for yes in the chat section. This won't impact CPD allocation at all. It is just for their own attendance records. I'm now going to hand over to Dr. de Waard and I'll start her presentation for her. Thank you so much.
Thank you, Claire. So good evening, everyone. So when they asked for someone to talk on the topic of cesarean section infections, I volunteered myself because I'm very interested in cesarean sections and everything related to it. So tonight we will be talking a bit on the management and the prevention of birth-related wounds and post-cesarean section infections. And this is always topical and important in South Africa. As most of you know, our cesarean section rate continues to increase. I think the national rate is almost 29% now, and so also are the infections associated with it. And sadly, pregnancy-related infections remain one of our leading causes for maternal mortality in the country. So very important. So let's just go back to some basics and look at the definition. So what is a surgical site infection? And I think most of us working in healthcare have become quite familiar with the Center for Disease Control and Prevention, as they published lots of data on COVID-19. But according to them, the definition is a surgical site infection is an infection that occurs after surgery, that seems quite obvious, in the part of the body where the surgery took place. So surgical site infections can sometimes be superficial, involving only the skin, and other times it can be more serious, involving tissue under the skin, as well as the organs or implanted material. So we've recapped that, surgical site infection. Then what are birth-related wounds? And in this sort of sphere of birth-related wounds, they often use this acronym, CRPT. So I will be using it a bit in this presentation as well. So CRPT stands for childbirth-related perineal trauma. So this can be spontaneous trauma or surgical trauma, such as an episiotomy, to the perineal tissue during vaginal childbirth. CRPT, childbirth-related perineal trauma. So either trauma, a tear in other words, or a cut to the perineal tissues. And then other childbirth-related wounds are incisions that are made in the tissue of the abdomen to perform a planned or emergency cesarean section. So in other words, in the terms we use every day, it's either perineal tears such as second or first or third, fourth degree tears, episiotomies, or then cesarean sections. So these are all considered to be childbirth-related wounds. So a little bit on the history. I went into look. So childbed fever was a term that was used in the earliest documents found on mortality associated with childbirth. So you can see that sepsis or infection after childbirth has been prevalent and present for millennia. In the 1800s, when the germ theory and the discovery of antiseptics were made, only then we started to see some improvements in these deaths. Globally, obstetric sepsis remains the third direct leading cause for maternal mortality, and like I've mentioned in the start, in South Africa specific, obstetric sepsis is our fifth leading cause for maternal mortality. So it's estimated that almost 75,000 maternal deaths per year occur due to infections, and that those are a lot of mothers that die because of this condition. So how common is it? You get varying reports in the literature of the incidence of cesarean section or childbirth-related wounds. Globally estimated between 2.5 and 16%, but the global estimate is about 5%. And most of these occur between day 4 and day 7. So usually after discharge, more than three quarters of these infections will occur. In low and middle income countries, the infection rates are between 0.8 and 11% documented in the literature. About 23% after childbirth, almost a quarter of women will have some kind of infection in the genital tract after childbirth. That's quite alarming. For South Africa specific, there was limited published data, but in some of the studies I found, there was a dissertation done in Tygerberg, so in high-risk patients, the post-cesarean section wound rate was 4.5%, and in a study done in KwaZulu-Natal, it was about 7%. But the point is of all of this, it is common. If you think 5% of all pregnancies, we see a lot of infection post-childbirth. So let's look a bit more specifically at genital tract infections, and I've just included this picture from Up to Date to sort of have a visual of the genital tract. I think we're all familiar with it, but we're going to talk a bit about infections of the genital tract and how to prevent them and to treat them. So what are risk factors for getting genital tract infections? So first of all, risk factors, obviously you first need a tear or trauma to the genital tract. So things like episiotomy, third and fourth degree tears are risk factors. Any assisted vaginal delivery, forceps specifically, but also vacuum deliveries when there are tears of the genital tract would be a risk factor. Things that affect the general health and immune system of the mother, such as smoking. They found that repair by a midwife, and I don't think it's to do with the skill of the midwife, but it's probably to do with the circumstances under which the midwife has to do the repair, increases the risk. Most of the repairs done by physicians will be done in theatre. It would mostly be the 3rd and 4th degree tears. The experience of the health practitioner that does the repair also influences the risk for infection. The use of chromic or catgut sutures. A body mass index of more than 35 kilograms per meter square is a risk factor for perineal infection. Prolonged rupture of membranes, which makes sense. So if there is already some underlying or subclinical chorioamnionitis, and then the nutritional state of the patient. So also the low BMIs. And as most of us who work in obstetrics in the public health sector know that identifying women with high and low BMIs is an important screening mechanism, and one of their risks would then be infections. Some of the other risk factors that are not modifiable includes maternal age. So older age women have a higher risk. Meconium-stained liquor. The birth weight of the baby, that is also quite logical. The higher the birth weight, the bigger the chance for perineal tears and trauma. And primiparity was found to be a risk. When on the Cochrane review concerning prophylaxis to prevent maternal infection after childbirth, and I've just added a little photo of it. It's not for the details, just to show it's from that Cochrane review. It was really found that only after obstetric anal injury, so 3rd and 4th degree tears, was there good evidence for the use of antibiotics as prophylaxis. There was not good evidence for the use of antibiotics in any of the other circumstances. So they recommended a single dose antibiotics after 3rd and 4th degree tear repair. How do we then prevent these infections? If we know the risk factors, can we prevent it? So the first way of preventing it would be to avoid trauma. Obviously, to try and avoid any unnecessary trauma to the genital tract. It's not always possible, but as much as we can. If we do need to do a repair, to use an aseptic technique and to clean the perineum, not only with sterile water, but with chlorhexidine or iodine. That is recommended by the NICE guidelines. It's important to educate the patient on the signs and care after discharge. As I showed you in one of those first slides, most of these infections occur between day 4 and day 7 when the woman has already gone home. So try to educate them on what signs to look out for, on how to actually prevent or how to identify infection. This should also then alert them to present early to healthcare facilities. So specific information that you should give on discharge is education on the type of sutures that were used for the repair. So if they are absorbable or whether they need to be removed. I think patients can become quite anxious if they're not aware that the sutures that we use are actually absorbable. You should educate them on bowel movements, on the fact that they should not try to avoid constipation, improve their diet, and on sexual intercourse. So the recommendation is to not commence with sexual intercourse before all the wounds have completely healed. Then the women will need regular follow-up. The postnatal visits are very important, especially during the first 3 weeks, with review of any perineal tears, and then hygiene. So hygiene information that you should give the patient is to change their menstrual pads regularly. Cold packs can be used after delivery for the first 24 hours. It hasn't, the only evidence for is that it improves symptoms. It doesn't specifically decrease infection, but it does show to be beneficial for symptomatic relief. So those frozen ice packs. Squirt bottles for perineal care. Again, the evidence is quite limited, but it has been shown to be beneficial for the women to relieve symptoms during urination. So they can use a squirt bottle with water to clean their perineum or to squirt on the perineum during urination. And sitz baths was something that I was also wondering about, whether there is good evidence for that. We always recommend that. And when I looked into the evidence for this, there's limited data, but it is recommended by the NICE guidelines, 5 minutes up to 4 times a day or after a bowel movement, not longer than that. But there's a lack of evidence for the temperature of the water or for the use of salt. So when they talk about sitz bath, it's basically just a water in a bath. So 5 minutes for 4 times a day and after bowel movements seem to show benefit. Okay, so these are ways of prevention. If there is an infection, what are the symptoms that we need to look out for? So severe pain is a concern. Usually we would expect pain to improve a little bit with every day after the delivery. So if pain becomes worse, again, that can be a concerning feature. If the pain is more severe than the previous day, that is something the patient should be aware of. Fever is obviously a big concern, and malaise. So systemic signs of infection, a bulging perineum or a mass in the perineum, and then obviously any abnormal discharge from the rectum or the vagina. So these are some of the symptoms that patients can look out for. Signs of infections, and this is an image from the Journal of Wound Care, which is an excellent document. So erythema of the skin, so redness of the skin, shiny, tense skin, a draining sinus with discharge, edema or swelling, the presence of a mass or an abscess, especially if it fluctuates. And then you need to do a full clinical examination. So look for systemic signs, look for fever, temperature, increased pulse rate, respiratory rate. If the perineum is very tender or very swollen or edematous and you're unable to fully examine the patient, then they recommend that you should even consider sedation or an examination under anesthesia. So management, how do we then manage these infections if we've made the diagnosis? If it's limited to the soft tissue, oral antibiotics is usually sufficient, broad spectrum antibiotics, such as amoxicillin and clavulanic acid. If there is an abscess, remove any sutures and drain the abscess and irrigate locally. If the abscess is large or there's deeper tissue involvement, these patients will need to be debrided in theatre. So then you require IV antibiotics, IV broad-spectrum systemic antibiotics, and full debridement of any devitalized tissue in theatre. If there are systemic signs, you need to evaluate for necrotizing fasciitis, and then you need urgent IV antibiotics and extensive debridement. Separation and breakdown commonly present between day 10 and day 14 post-delivery. And excuse me, the meta-analysis show that healing by secondary intent is equal to secondary closure. So in first and second degree tears, if there was breakdown of a wound secondary to infection, after the infection was treated with antibiotics and irrigation, those women do not need to be taken to theatre to close that tear again. There's similar outcomes. By 3 weeks, 70% of them will be healed by healing by secondary intent. But for third and fourth degree tears, you will need debridement during the acute infection, treatment with antibiotics, and those patients will require a secondary repair. And then it is recommended that this repair is done by a specialist to try and avoid anal sphincter, long-term anal sphincter damage or incontinence. So that was on the genital tract injuries and infection. Now we're going to look more specifically at post-cesarean section infections. And I'm just going to start with this message. There was clear evidence that the implementation of surgical site infection bundle, and I think most of us working in the healthcare system would be familiar with the SSI bundles, does show clear improvement in the sepsis rate. SSI bundles usually include aseptic skin considerations using chlorhexidine, so chlorhexidine and alcohol for cleaning the skin of the abdomen, prophylactic antibiotics within 60 minutes of the cesarean section, and closure of a subcutaneous layer if that subcutaneous or fat layer is thicker than 2 centimeters. You need to close that layer in addition to your skin closure. And those 3 factors has the most evidence for improving infection rates. So what are risk factors for post-cesarean section infection? So one of the big risk factors is unscheduled delivery. So an emergency cesarean section is at much higher risk, and especially a second stage Caesar. And we know that women with second stage Caesars, so Caesars where the woman is already in the second stage, she's fully dilated, sometimes the head is quite low. We've already probably by that point attempted an assisted delivery. So there's lots of contamination with the genital tract. Now we do the cesarean section, we deliver the baby, and that contaminants from the genital tract goes in through the abdomen. And that is obviously a big risk for infection, and we need to be aware of that. Other risk factors include obesity, and our obesity pandemic in the country means that we're seeing more patients with obesity and patients with worse levels of obesity and higher BMI. So that is definitely a concern. And unfortunately, women who are obese tend to have more difficult labors and sometimes higher cesarean section rates, especially if we need to induce them. Other factors that can affect the health of the mother, such as substance abuse, smoking, alcohol, and illicit drugs, are all risk factors for infections. Chorioamnionitis, that makes sense. So if there's already an infection present, vertical skin incision is a higher risk than a transverse incision. A blood transfusion in itself is a risk factor for wound infection. It's obviously compounded by whatever caused the bleeding in the first place. Another factor that's a big risk for infection in the wound is a subcutaneous hematoma with an odds ratio of 11. So good hemostasis is very important during cesarean section. A procedure that's done at the teaching service has a higher risk for infection. And the use of skin staples appears to be a higher risk than the use of sutures for closure of the skin. And I've just added some of this data to show you the odds ratios. It's quite interesting for me. So the risk of infection after a cesarean section versus vaginal delivery, the odds ratio is 4.7. So obviously a cesarean section in itself is a higher risk for infection. If labor was present at all, that is a risk factor. If the membranes were ruptured for longer than 18 hours, so that also has a high odds ratio of 3.3. Obesity, again, that makes sense, and we are aware of that. The number of vaginal examinations. So I think we're all aware of that. So if the numbers of vaginal examination during labor exceed 7, that was independently a risk factor. So more than just being in labor. The absence of antibiotic prophylaxis. So we clearly know that antibiotic prophylaxis is very important to prevent infection, and diabetes is also a risk factor. And this table is adapted from this interesting article, Infectious Morbidity After Caesarean Section, 10 Strategies to Reduce Infection. And I would recommend you read that if you're interested. So how do we prevent these then? Education again. During the antenatal period, education is very important. The NICE guidelines recommends perineal floor exercise, information on postnatal self-care. They recommend that you give that at 36 weeks. Smoking and other substance cessation, obviously very important. And to identify the risk factors. Postnatally, WHO recommends only discharge after 24 hours after vaginal delivery. Information on how to care for childbirth perineal trauma and evaluation of this at the postnatal visit. We need to adequately educate patients on signs and symptoms of infection and inadequate repair, wound breaking, and non-healing. So how do we prevent infection during labor and delivery? We need to follow labor and delivery guidelines first and foremost, and we need to avoid any unnecessary cesarean section. So this is very important. We need to use the partogram. We obviously we should avoid unnecessary inductions. So that's the first step, is just to try to avoid a Caesar in the first place. If we do need to do a cesarean delivery, obviously we need to use aseptic techniques during labor as well. We need to avoid unnecessary vaginal examinations in labor. And the number of vaginal examinations recommended by the new WHO partogram is less, so we need to stick to that. We need to avoid unnecessary instrumentation in labor, so only do instrumental deliveries if they are indicated. And it's very important in women with diabetes to control diabetes as good as possible. And these are recommendations from the NICE guidelines. Perioperatively, the patient should shower or bath the day before the cesarean section. Do not do routine hair removal. That actually increases the risk. If you do need to remove hair, clip rather than shave. The patient needs to wear theatre wear. The staff also needs to wear appropriate theatre wear, and we need to minimize the movement in and out of the theatre. Bowel preparation is not recommended. Operating team should remove hand jewelry, artificial nails, nail polish before the operation. That was also an interesting one, and I was wondering if there's actually evidence for that. And the evidence is based on the fact that with artificial nails, they've done microbial swabs on the healthcare workers with these nails, and there's much higher bacterial colonization. So there's a clear recommendation that nail polish and artificial nails are contraindicated for people in the operating theatre. Correct technique for surgical hand washing is very important. So really, we need to go back to the basics and do these things right. Everything does contribute. The wearing of sterile gowns in theatre, the using of gloves. So they recommend use 2 pairs if high risk for perforation or the consequences are serious. 2 pairs in itself does not decrease or impact the risk of infection. So wear 2 pairs of gloves where you would have to protect yourself. Okay, so on the Cochrane review for the use of antibiotics prophylaxis at cesarean section, this is the recommendation. So the timing, it should be 60 minutes before the skin incision. Cefazolin is recommended 2 grams intravenously if the weight of the patient is less than 120 kilograms. If the weight is more than 120 kilograms, they recommend the use of 3 grams. They recommend the use of a second dose if the blood loss is more than 1,500 milliliters or if the operating time exceeds 4 hours. So we need to keep that in mind. They also recommend, if there is a penicillin allergy, a confirmed penicillin allergy, to use clindamycin 900 milligrams and gentamicin 5 milligrams per kilogram as the prophylaxis, plus an additional dose of azithromycin of 500 milligrams for patients in labor or with ruptured membranes. So these are the recommendations for antibiotic use. Skin and vaginal preparation. So we're still talking about preventing infection during cesarean section. So you need to clean the skin with chlorhexidine and alcohol. That is the first choice. Or iodine alcohol or povidone iodine or chlorhexidine soap. If there is a contraindication to the chlorhexidine alcohol, but that is the first choice. They recommend that patients who were in labor, where the membranes were ruptured, we should use 4% chlorhexidine gluconate to clean the vagina. You can also use povidone, which is less effective. But this does show a reduction in endometritis, not specifically wound infection, but it does decrease infection. We need to use non-adhesive drapes, as these show less wound infection. During surgery, what is important for the surgeon to keep in mind? Limit traffic through the operating room. I did a short exchange in the Netherlands, and in those operating rooms, it was very interesting. They would give you 10 points to start off with. It's an electronic artificial intelligence system, and you see your 10 points very clearly. And every time that someone opens the theater door, you lose a point. So from the start of the surgery, every time somebody comes in and out of the theater, you will lose a point. And this sort of gives you immediate feedback, but it does make you aware of traffic in the operating room. Skin prep, like I said, alcohol base is the first choice. Obviously, we do not use alcohol close to mucous membranes, so we do not use it on the vagina. So close to the mucous membranes, we use aqueous base chlorhexidine solutions or povidone. Do not use diathermy for surgical incision. Diathermy increases the rate of infection for surgical incision. Maintain homeostasis. So that's very important. Maintain the temperature of the patient, not hypo or hyperthermia. The saturation, so the perfusion and the oxygenation of the tissue during surgery will also improve or decrease your risk for infection. So there must be good perfusion. Be aware of undue pressure on parts of the body. I know that when we do cesarean sections for women with a big pannus abdomen, we tend to ask a few people to assist, and we pull and we put lots of pressure on that wound. So we really need to be aware of that. And if that tissue is sort of pushed out of place for a very long time, the perfusion to that tissue will be poor, and this can then increase the risk for infection. Blood glucose control is very important, especially with diabetics. Irrigation or lavage is not recommended, and hemostasis is very important. Like we said, hematoma is a risk factor for infection, so we need to be meticulous about hemostasis to avoid hematoma formation from the uterine site incision, on the muscle layer as well, above the rectus sheath and in the skin. At every step and level, we should assure good hemostasis. So theater technique is very important, or surgical technique, and theater decorum, and all of these factors play an important role in preventing infection. So skin closure, they recommend the use of antimicrobial coated sutures. That's not readily available in the public health sector, but if you do have that available, it does show some improvement in infection rate. They recommend the use of sutures rather than staples to reduce the risk of superficial wound dehiscence. And they do recommend to close the wound with an interactive dressing. other than just a simple gauze dressing. So interactive dressings does show improvement or a decrease in infection rates. So how do they then avoid infection in the post-operative phase? So we've talked about antenatal period, we've talked about factors during labor to consider, we've talked about factors during surgery to consider, so now post-operatively. When changing dressings, use a no-touch technique, so make sure that the actual wound remains sterile. You need a sterile saline to clean if we need to change the dressing before 48 hours. After 48 hours, normal tap water can be used, and a patient can shower after 48 hours. So when we think in this article that I read on the infectious morbidity and the 10 strategies, they classify risks in 3 categories. So low, moderate, and high. And low risk would be elective cesarean section, absence of diabetes, normal BMI, and a low surgical case. So in other words, it's not a complicated surgery. A moderate risk factor would be non-elective, so after labor or rupture of membranes, women with well-controlled gestational diabetes or body mass index between 25 and 35, moderate risk surgical cases, or if they required a manual extraction of the placenta or closure of the skin using staples. And high risk for infection would be emergency cesarean section, often performed without adequate skin prep or antibiotic prophylaxis. So if we think about our very severe emergencies, such as a cord prolapse, sometimes there is not time to perform all of these steps adequately. If there's already chorioamnionitis present, it is poorly controlled pre-gestational diabetes, if the body mass index is above 35, if it's a difficult surgical case, or if we required manual extraction of the placenta and closure of the skin using staples. So it's just good to know how to classify patients and what are their risks for infection. And this would help and guide you with your post-operative management plan. So what are these 10 strategies that they then recommend to prevent post-cesarean section infection? The first one is to shower with 4% chlorhexidine gluconate the night before the surgery. Again, don't shave pubic hair, clip. Avoid unnecessary vaginal examinations. Avoid unnecessary instrumentation in labor. So these include fetal scalp electrodes or intrauterine pressure catheters. Prepare the skin with antiseptic chlorhexidine alcohol preparation prior to surgery. Administer appropriate prophylactic antibiotics within 60 minutes prior to incision. Avoid manual removal of the placenta and the fetal membranes. And with that, avoid cleaning of the placenta of the uterine cavity with a swab. So rather allow for spontaneous delivery of the placenta during cesarean section. Avoid closure of the skin with staples. Maintain strict glycemic control in women with diabetes. And consider early removal of catheters post-operatively. So now let's talk about the treatment of infections. So the CDC, again, Center for Disease Control, they classify surgical wounds in 4 ways. It's either a clean wound or a clean contaminated wound, or a contaminated wound, or a dirty or infected wound. So here is just a image of the skin and the subcutaneous tissue, the deep soft tissue, and the organ space. So also the levels of infection that you can get, superficial infection or deep or organ space infection. So in this classification, the clean or class 1 wounds, uninfected operative wound in which no inflammation is encountered, or on entry, and all the respiratory, elementary, genital, tracts are not entered. So it is just through the skin and it's clean. Clean contaminated wound, operative wound in which the respiratory, alimentary, genital or urinary tracts are entered under controlled conditions and without unusual contamination. So this is the case for most cesarean sections. We do enter the peritoneal cavity, but in clean and controlled environment. Contaminated wounds, so these are open, fresh, accidental wounds or operations with major breaks in sterile technique or gross spillage of the GIT, so a bowel injury or incision with acute non-purulent inflammation. And then infected wounds or all traumatic wounds with retained or devitalized tissue or those involving existing clinical infection. So how do we then diagnose wound infection? This is an image. I've referenced the website below. So erythema, so obviously redness of the skin, induration, so any swelling of the skin, warm to touch, pain, again, pain that's out of keeping with the days post-operatively. Most surgical wounds should improve a little bit each day. If the pain becomes worse, it's a reason for concern. So I also tell women after discharge, if they are starting to feel worse again, if the pain becomes worse, they need to come back for review. Any purulent wound drainage, any separation of the wound, and then obviously any systemic signs. So any signs, fever, tachycardia, signs of systemic inflammatory response, and then necrotizing fasciitis, which we'll touch briefly on at the end, which is the most serious. So treatment. So we've identified the risk factors. We've now identified the infection. How do we treat? Firstly, appropriate antibiotics, and usually we will start with broad spectrum antibiotics. Discuss also with your local microbiologist. It depends whether the patient has already been treated with antibiotics for another condition, how long she's been in hospital, and which ward she was in. So in places like ICU, obviously you need to tailor your antibiotics. There might be more resistant patterns. But in most cases, a broad spectrum antibiotic with good skin penetration, such as ampicillin and clavulanic acid, would be the first line antibiotic, but again, use appropriate for your setting. And then surgical treatment, so the wounds need to be opened, explored, drained, so remove the sutures or the clips. Irrigate with saline. If there are devitalized tissue, this needs to be debrided. If the fascia is interrupted or disrupted, so if the sheath is open, that patient needs to go to theater. Again, or if there's lots of devitalized tissue, you need to take the patient to theater. So in theater, again, remove all devitalized tissue. If the fascia is disrupted, inspect the abdominal cavity to make sure that there's no collections of pus inside the abdomen. And you will also need to clinically assess the uterus to see whether the uterus is involved and infected as well. After that, dressings. So deep wounds need to be packed with gauze and saline. If this is a patient that did not go to theater, that's going to assist with debridement. So ideally for healing, we need to actually absorb the exudate without leaking in the skin. So we need to remove the fluid, the excessive fluid from that wound. Negative pressure therapy is preferred if it's large wounds. So vacuum dressings works well, and there's good evidence that it does work for large wounds. Again, it assists by basically removing the fluid, which, if it was still there, will aid bacterial growth. And then once the infection is cleared and granulation is starting to appear, closure can be considered. And this will obviously depend on the extent of the wound, whether this closure can be by secondary intent or whether the patient needs to have a closure in theatre. So just a word on dressings. There's different types of dressings, and I did find it a bit overwhelming that is used for treatment and for prevention, and they have different features, and it's good to speak to your wound care specialist regarding this and the options available. But basically, like I've mentioned before, you get advanced dressings or interactive dressings, as it's called in the NICE guidelines. And then you also get simple dressings. And this was a systematic review where they looked at advanced dressings versus simple dressing for preventing surgical site infection in women post-cesarean section. And you can see on this forest plot, it does seem to want to favor the advanced dressings, but there was some heterogeneity in the studies. But these two studies by Staranowski, where they used DACC impregnated dressings, did show statistical significant reduction with SSI with advanced dressing. So there does seem to be evidence for the use of advanced dressing in preventing infection. And then necrotizing fasciitis. So lastly, just something on necrotizing fasciitis. So this is a serious infection of the deep soft tissue. It's very serious and can be lethal. And sadly, we have even lost patients after cesarean section from necrotizing fasciitis. And the infection causes progressive destruction of the muscle fascia and the overlying subcutaneous fat. It can either be polymicrobial, so different organisms, anaerobic and interbacteriae like the KEEPs, or monomicrobial, so group A, Streptococcus, beta hemolytic Streptococcus, or Staph aureus. The clinical signs which you need to look out for: erythema without sharp margins, edema that extends beyond the visible erythema, severe pain, so out of proportion to the exam findings in some cases. And these first three signs, erythema, edema, and the severe pain, is usually present in about 72% of patients. Fever, crepitus is obviously a concerning feature, so something is forming gas under that skin, and that is usually bacteria. So if crepitus is present, we should be very concerned. So skin bullae, so there is sort of blistering on the skin. Blistering of the skin, again, very concerning. Necrosis or ecchymosis. And then if the wound is draining a dishwater-like fluid, the tissue is dusky, pale, and devitalized. So basically, the tissue is dead. Necrotizing, necrosis of the tissue. So the bacteria has caused necrosis of the tissue. The tissue is dying, and this is causing this discharge. How do we manage these patients? They need to be managed at a center where there are high care or ICU facilities and specialist care with goal-directed resuscitation, so support the organ systems. They're often in septic shock. Early onset, early broad spectrum appropriate antibiotics, but send away the bacteria. And then prompt source control. So take the patient to theatre, and we often need to extensively debride until we've removed all the devitalized tissue. But this is really an emergency and can be lethal. So, to recap and summarize, what is the take to work message here? And I've chosen a few icons which I found appropriate. So firstly, it's common. Birth-related wounds and post-cesarean section infections are common. They are also serious, so they can cause mortality. So it's very important for everybody that's working in obstetrics and with pregnant women. Prevention is key. We need to modify, or we need to identify patients at risk. We need to modify risk factors where possible, and we need to prevent it in the first place. If we can't prevent it, then we really need to recognize it very early. Again, patient education saves lives. Tell these women when to come back. The earlier we start the treatment, the quicker we can resolve it. And once we've made a diagnosis, active and aggressive management will prevent morbidity and mortality. We need to get source control. So this is the end of the presentation. These are the references. Some of the references that I can really recommend is the Journal of Wound Care, the NICE guidelines on birth-related wounds and infection, and then the article on the 10 steps to avoid infection. Thank you.
Very much, Dr. de Waard, for educating us tonight on such an important topic. And I can't believe that there are so many deaths associated with infection and sepsis, you know, in this day and age. And it really is mind-blowing for me, but I suppose it can and obviously does happen. There's one question so far. I'm concerned that you do not recommend a topical antimicrobial dressing to manage.
Thank you for that question. Yeah, so for the prevention, there was clear recommendations for the interactive dressings. For the management, that will depend on the case scenario. So the mainstay of treatment is first to get source control, the surgical management, and then you can use the antimicrobial dressings. So I didn't recommend against it. But I didn't specifically go into that detail. But that would be sort of a clinical decision on that specific scenario.
Okay, there's a follow-up question. Infection as per the International Wound Infection Institute Guidelines 2022. Is there a reason for this? Similarly, wet to dry debridement with wet gauze dressings is no longer recommended. Is that something you'd like to comment on?
Yeah, I know. I mentioned the wet, and in the guidelines that I read, they recommended that, but I will look into that 2022 guidelines. So thank you for that. I'll take note of that.
Okay. If there are any other questions that the audience you'd like to ask, please do ask them. We have Dr. de Waard available. I must also say to the audience that would you be interested in receiving a print copy of the best practice document? If you are interested in receiving a print copy of the best practice document, please type yes in the chat box. I'm just going to put this instruction there now so that we don't mix it up with the attendance register. But if you can write out the full word yes, SAT will get that document to you if that is something you would like. There's another comment. In the past, we were wrongly putting Kefzol powder it just says in the W. I suppose they mean in the wound.
Wound, yeah. So that is not proven to be evidence-based. But I've read about that as well, yeah.
Some more questions. Can laser therapy be helpful for the wound post-cesarean section?
Sure, there wasn't anything in the evidence that I reviewed about laser therapy specifically, no.
Okay.
I think the most I saw about that, is sort of for scar tissue, but I'm not aware of its effect on actual active infections.
Right. Is the use of surgical spirits increasing the risk of wound sepsis?
Is the use of surgical spirits increasing the risk of wound sepsis? I don't have the answer for that. I'm not sure. Do you mean if women use surgical spirits to clean their own wounds at home? I don't think there was anything specific published on that. I don't know if that's a practice that's more common in South Africa than globally. Yeah, sorry, no, I don't have that answer.
Okay, then please advise regarding the use of prophylactic mupirocin, I'm not saying the brand names, on cesarean scars.
Yeah, there wasn't evidence for that either, to prophylactic use of topical antibiotics. That didn't seem to be beneficial. I think that will also be costly.
Okay. Is it recommended to give prophylactic antibiotics for all post-cesarean section patients, whether high risk or low risk?
Yeah, so one dose prophylaxis is recommended for all cesarean section patients before the incision. 60 minutes before.
Okay. So just some clarity about the document that I mentioned. It's the latest copy of the EWMA document on birth-related wounds from ewma.org. So if you would like that, please type yes in the chat section. Is it recommended to leave the cesarean section site opened without any dressing on discharge?
No, it's recommended to use a dressing on discharge to prevent infection, but after 48 hours, the wound can be cleaned with normal tap water. But the recommendation is that the dressing will prevent infection.
Okay. Would you recommend hydrogen peroxide for septic wounds?
I know hydrogen peroxide was investigated a bit for the use in conditions like necrotizing fasciitis, but there was no recommendation for that. So the evidence didn't show it to be beneficial. No.
Okay. Some yeses coming through for that document. Just keeping my eye on the various chat sections. Informative and concise. Thank you. Okay. So this came through as a private comment. Would you agree that what we can put in the eye, we can put in the wound?
Sure, it's difficult questions. What you can put in the eye, you can put
what
in
you're
the
putting
wound.
in your eye.
In the eye. It seems now that I think about it, it does seem sort of logical. I'm assuming they imply as advice for patients, and it's more to deter them from putting anything into the wound, as they probably wouldn't put anything specific into their eyes. I'm not entirely sure whether you should be putting your eye drops for your glaucoma into the wound. I don't think that would be such a good idea, but probably best to not put anything in there.
Okay. Would you recommend that in case of high BMI, staples are more advisable than sutures? And if so, what BMI cutoff?
Yeah, so the question of staples versus sutures is quite topical. And the evidence is not very clear in women with obesity. So the most of the evidence in women who are not obese, the recommendation is to use sutures. So I can only assume that for women with a high BMI, sutures would also be beneficial. The only thing that the evidence does show for closing the abdomen, if there is a thick pannus more than 2 centimeters, is to put in that subcutaneous suturing, but there isn't good studies on high BMI women. I have looked specifically at that as well, so I can't recommend anything, but it does seem in the lower BMIs definitely that sutures are beneficial. Claire has left the room, it seems. I don't know if that implies that this is the end of the webinar. Thank you for all the interesting questions. Claire has joined the room again. Okay, thank you.
Apologies, I was copying and pasting there and my finger slipped, so sorry for that.
No problem.
I was copying and pasting the message about the document and that people must type yes. So I didn't see if any new questions came in, and now it's kind of erased the previous questions. So I don't know if you have seen any new ones.
No, I think the last question that I'm seeing is still the BMI question. What type of sutures? Now there's a question.
Yeah.
No, there's no clear recommendation whether we should be using. Actually, to be honest, the recommendation is just subcutaneous sutures but those are for the low BMI patients. So whether the mattress sutures that we routinely use is recommended versus clips, we'll have to do some research on that. That there's not a clear recommendation for that.
Okay. If there are any other questions, please do let us know. And if you would like to receive the printed copy of the EWMA document on birth-related wounds, type yes, and SAT will get that to you. But other than that, I want to thank you so much for your time and effort in compiling and presenting this webinar tonight, Dr. de Waard. We really do appreciate your expertise on this matter. And thank you so much for joining us, to the audience. I see a suture material. Okay, you have addressed that. Someone's just asking.
Yeah.
Okay. So thanks again, audience, for joining us tonight, and to SAT for making this webinar possible. It really is an important topic, and I can only hope that these maternal deaths decrease with increased knowledge and increased. I like the way you put it. You said surgical theatre decorum, and being aware of that infections are life-threatening. So everyone has to be careful, and the patient needs to know how to look after their wound post-cesarean as well. So, okay, thank you so much, everyone, and have a great evening further. And we are hosting a webinar tomorrow night as well, so please do see our advertising for that, and do join if you are keen to learn about the psychiatry topic on elderly people. Okay. Thank you so much again, Dr. de Waard, and good night, everyone.
Thank you. Thank you. Good night.
Bye.
Bye.